Hello everyone, my name is Rahul Srivastav from A4 Medicine. Today we're using a primary care blueprint for osteoporosis and fracture risk. The focus is not just diagnosing low bone density, it is preventing the next hip, spine, wrist or humerus fracture by identifying risk early, calculating it properly, and knowing when to scan, treat or refer. In the UK, osteoporosis affects around 3.5 million people and causes more than half a million broken bones each year. That is roughly one fragility fracture every minute. The major burden is not just pain, it is loss of mobility, reduced independence, care needs, and a cost to health and social care of more than £4.5 billion each year. Who requires assessment? NICE makes this simple. Women aged 65 and over and men aged 75 and over should have fracture risk considered routinely. Below those ages, we do not screen everyone. We look for triggers such as previous fragility fracture, steroid use, falls, low BMI, smoking, alcohol excess, parental hip fracture, or secondary causes. This topic is taken from our A4 Medicine Primary Care My Disease series. This endocrinology book is built for fast clinical use, short sections, practical decisions, and AKT friendly recall. It is written for GP trainees and frontline clinicians who need endocrine guidance that can be used quickly in real consultations. In younger adults, osteoporosis usually needs an explanation. A prior low trauma fracture is a strong warning sign. Long term oral steroids, especially prednisolone exposure over several months, can weaken bone quickly. Low BMI, smoking, alcohol excess, recurrent falls, and parental hip fracture all shift someone from too young to worry into needs risk assessment now. A significant minority of osteoporosis is secondary, meaning another disease or treatment is driving bone loss. Think endocrine disease such as hypothyroidism, Cushing's or hypogonadism, gastrointestinal disease such as celiac disease or malabsorption, inflammatory disease such as rheumatoid arthritis, CKD, and premature menopause. The clue is often severity that feels out of proportion to age. Before opening a calculator or requesting DXA, get the basics right. Ask about previous fragility fractures and falls. Measure height and weight accurately because BMI changes the risk estimate. Look for kyphosis or height loss. The National Osteoporosis Guideline Group, we'll call this as NOGG here, highlights 4 centimeters or more of height loss, kyphosis, steroid exposure, or acute back pain as reasons to think about vertebral fracture assessment. Both the tools, FRAX and QFracture, estimate fracture risk, but they are not the same. FRAX gives a 10-year probability of major osteoporotic fracture and hip fracture and can include femoral neck bone mineral density. QFracture is based on UK primary care data and includes more comorbidities. The key practical point is this. NOG thresholds are FRAX based, so do not directly map a QFracture result onto NOG treatment bands. NOG turns risk into action. Low risk means reassurance, lifestyle advice, and review if circumstances change. Intermediate risk is a decision zone where DXA helps refine probability. High risk usually means treatment should be considered. Very high risk, for example, recent vertebral fracture, multiple vertebral fractures, T score minus 3.5 or lower, or high dose steroid exposure should prompt specialist osteoporosis input. DXA is best used when it changes management. NICE advises against routinely measuring bone mineral density before clinical risk assessment. In primary care, the usual sequence is calculate risk first, scan if the patient is near a threshold, then recalculate risk with BMD. DXA is also useful as a treatment baseline or when starting therapies that accelerate bone loss, such as aromatase inhibitors. A T-score shows how far patient's bone density is from a young adult reference range. Above -1 is normal. Between -1 and -2.5 is low bone mass, often called osteopenia. -2.5 or below meets the densitometric definition of osteoporosis. But remember, fracture risk is not just a T-score. Age, falls, and clinical history matter. T-scores are mainly for postmenopausal women and men aged 50 or over. In younger adults, Z scores are more informative because they compare the patient with people of similar age. A Z score of -2 or lower means bone density is below the expected range for age. So do not just label osteoporosis, actively search for a secondary cause. Baseline bloods do two jobs. They check treatment safety and look for hidden causes. Calcium, phosphate, alkaline phosphatase, and vitamin D assess bone and mineral status. Renal function matters because bisphosphonate choice depends on kidney function. Full blood count, ESR or CRP, liver tests, and thyroid function tests can reveal inflammatory, malignant, hepatic, or endocrine drivers of bone loss. Targeted tests should follow the clues. Repeated high calcium points towards parathyroid hormone testing. Gastrointestinal symptoms, iron deficiency, or low vitamin D may justify celiac screening. Osteoporosis in a man or premature menopause should trigger gonadal assessment. Abnormal blood count, raised inflammatory markers, or bone pain should make you think about myeloma screening with electrophoresis and free light chains. Red flags are patients whose osteoporosis pattern does not fit simple age related bone loss. That includes men under 75 or women under 65 presenting with fracture, anyone under 50 with low trauma fracture, multiple fractures, unusual fracture sites, poor response to bisphosphonate therapy. These are the cases where missing irreversible cause can lead to repeated fractures. The whole pathway is practical. Identify by age or risk factor. Calculate fracture probability with accurate height, weight, and clinical history. Use NOGG to decide whether the patient is low, intermediate, high, or very high risk. Add DXA when it refines the decision. Check baseline bloods, look for secondary causes, and then give lifestyle advice and start treatment or refer. Thank you for watching. This osteoporosis blueprint is part of A4 Medicine approach, fast structured primary care learning for real clinics and exam revision. For more endocrine and metabolic guidance, see the book Metabolic Problems and Endocrinology. This is available to buy on Amazon now. And for more such videos, please subscribe to our channel on YouTube, the A4 Medicine channel on YouTube. Thank you.